Herb Cohen again. Today I want to explore the disease model of trauma and addiction and just looking at why these models are failing. Our outcomes are not good when we're looking at these problems through this lens, and I'm going to explain why in this video. So the disease model is based on defining a disorder or labeling a disorder as a disease through a defined set of symptoms. So we're defining through symptoms and we're treating through symptoms. And basically what we're doing is we're either modifying or managing symptoms in these models. Okay? And the problem is that today we can actually do better than that. And we should. And ethically, we're obligated to do better than that. We shouldn't really be shortchanging someone if we can get them better. So let's take the trauma model, for example. So we have, if someone is lucky enough to be properly diagnosed with PTSD, um, they will probably see a doctor or a prescriber who will prescribe a pill for their symptoms. So if I'm presenting with anxiety, I will get a pill for that. If I'm presented with depression, I will get a pill for that. And if my mood is dysregulated, maybe I'll get a mood regulator. So these people will understand in not too long a term that their PTSD symptoms aren't going anywhere, that the medications only work to a degree, and that after a while, their trauma symptoms, if they stop taking those pills, they're right back where they were. And they also may understand that talk therapy isn't really going to work that well either, because they can talk and talk and talk and talk and talk and talk, and that's not how this works. So the disease model for post-traumatic stress, if we look at this, it's called a disorder, post-traumatic stress disorder. But if we actually understand what is happening, it's not really a disorder. What happens in the brain is the brain changes as an adaptation to being helpless and being endangered. Those adaptive changes help us survive. If we didn't have the adaptive changes, we wouldn't be here to talk about it. So we want those adaptive changes to take place. We don't want to devolve and not have that, even though it results in us being uncomfortable. So the issue here is that those changes are not a disorder. They're supposed to happen. We're supposed to be in fear and manifest anxiety and go into fight flight in order to survive, even though that makes us feel horrifically uncomfortable. The result of which is we seek to adapt. Internally, our brain can't adapt. It's been changed so that adapting internally doesn't work. So we have to then reach outside and we use drugs and alcohol, and therein we find relief, temporarily at least. And after a while we may find that we become addicted, and now we have another set of problems that we also call a disorder. But let's stay with trauma just for a bit. So pain, emotional pain, teaches us that we need to change, that we need to do something. Thus, we need to avoid pain. Wanting to avoid pain means getting recovery, means getting well, means getting treatment. And today, we can treat the cause of these problems by going to the causal memories. If we treat the cause and not the symptoms, we're actually going to eliminate the problem permanently. And here's where EMDR and sensory motor therapy and hypnotherapy, and there's a whole bunch of wonderful, wonderful psychotherapies designed to do this, designed to permanently remit any symptoms associated with PTSD, which in my opinion, is not a disorder. It's just an adaptive change that needed to happen to keep us alive. But our brain gets stuck, and we need to help it get unstuck. So getting unstuck, we have therapies for that work very, very well outside of a disease model where we're simply labeling and treating symptoms. Here, we're going to a causal model, and we're treating the cause, and we're getting rid of the problem. So let's look at the addiction model. So here people are the same people, basically. It's 1 in 5 people have had trauma lives happen to them. 1 in 5 people get severely addicted to drugs and alcohol. And it turns out that we're looking at the same group of people, because the people that I've worked with addiction have all told me the reason they use is to avoid pain. And when I look at their history, oh my gosh, they all have horrific trauma histories or misattachment. And there's a good reason to avoid pain, and avoiding pain is not abnormal. There's nothing disordered about avoiding pain. It's not a disease state if I want to avoid pain. It's normal to avoid pain. However, we know that that kind of pain avoidance can cause problems. It can cause problems for other people. It can cause problems for us. It surely ultimately does if we become addicted. And here's again where we're stuck. So in trauma, we're stuck because the brain freezes those memories, and we can't unfreeze them unless we go for specific therapies. Here in addiction, we're for 70 something years, 77 years or longer, we've been treating this by labeling it as a disease, saying this addiction is a disease, and here the brain adapted also to using drugs and alcohol. It adapted to that environment, and it's getting stuck. We need to get it unstuck. Same thing as with trauma. So we need to look at the causes of addiction if we want to get addiction treated. But if we manage the symptoms, all we're doing is managing behavior. We're looking at the symptom as someone drinking and drugging. That's the behavior we want to manage. In AA, we're looking at this as a disease model. AA says you're born with this. This is an allergy, and you have it for life, and you will die with it. And you need to surrender to that reason and follow the program as a way of managing your life without using. So we're managing one's behavior. In AA programs and rehabs, inpatient and outpatient, we're learning how to manage our lives without using drugs and alcohol. It's again managing the behavior, treating the symptoms. If we go to pharmacology and addiction, we're prescribing pills, oftentimes addicting pills. Suboxone is the new methadone. People are getting addicted to Suboxone. They're abusing Suboxone and getting addicted to it. They're using it with alcohol and creating tremendous damage. And why I call it the new methadone is because getting off Suboxone is like getting off methadone. It's nothing like getting off heroin or alcohol. It is much, much worse. And we're creating a brand new problem by marketing Suboxone as the answer to addiction, the pharmacological answer to addiction. It is not the answer to addiction. And when you stop using Vivitrol or Suboxone or any pharmacology, what do we have? We still have our addiction. We're not really treating the addiction. Again, here we're managing it. We can manage it chemically or we can manage it behaviorally. Either way, we're treating the symptoms in these disease models, and we're not getting anywhere. We're not really remitting the addiction, and even the behavior has an 80% relapse rate. So we're not doing a very good job of remitting even the behaviors. So let's look at a causal model for addiction. So what causes addiction? Well, here's where there's this tremendous secret. Even though there's the ACE study, which points to trauma and addiction and the relationship, it hasn't changed how people do intakes in outpatient programs or in private practices or in inpatient programs. So the government hasn't made regulatory changes to adapt to new information and new studies. But if we look at this and we say, well, there's a relationship between misattachment, trauma, and addiction, we can see that there are memories created that are responsible for the adaptive changes that take place in the brain, and that's why 1 in 5 people become addicted. It happened to be the same 1 in 5 that have misattachment and trauma. It's not an accident. It's a biological reason for it. We start storing implicit memory when we are traumatized very, very frequently. And we now know how to create, our brain knows how to create implicit memories, and it creates an implicit, a fixed memory out of using. And it switches on dependency. And that switch doesn't happen to someone who doesn't have a pattern of storing implicit memory. It only happens in 1 in 5. Only 20% of people become addicted. And that's why, if we know this, we can treat the addiction as implicit memory. When we do that, what happens to the dependency? It switches off, just like that. In one session, one EMDR session, we can switch off chemical dependency or alcohol dependency. Heroin, IV active using IV heroin addicts. We can switch off right in the middle of their day. We can switch off their dependency, even though they used that morning. This is without any withdrawal, no detox necessary, no rehabs necessary. Switched off. No allergy, no born with it diagnosis, no disease label. We just switch it off, and we work then on the causal reasons for their addiction, which may be the underlying traumas, and we make sure that those implicit memories are taken care of. So the person no longer is addicted at all. By all definitions, their addiction is gone. So here, going outside the disease models, we can go to a causal model in each domain and see the diseases to complete resolution. Why aren't we doing that? Why aren't we referring to people who can do that if we can't? This is our ethical responsibility to not do harm and to not mistreat or maltreat someone. We are really, really irresponsible if we are continuing to embrace these disease models. That is what I'm saying. And I think that's serious. I think this is a serious, serious statement that I'm making. I hope that you will challenge me on this. I will take you to toe here on this. I really think this is an important discussion to engage. We really need to engage this, and we need to take this further. So share this video if you think it's important, if you think the message is important. Feel free to comment and challenge me. I love the discussion. I want the discussion to happen. We need this debate right now. People's lives need this to happen. We need systemic, massive systemic change, and we need it now. So if you like this video, please like this on my YouTube channel. Subscribe if you want more, but this is really important. I'm Herb Cohen, and I'll see you again.